She actually passed away. She was 25 years old. She had rheumatoid arthritis, which could have been well controlled, but she decided to abandon all treatment, go to New Delhi, pursue alternative forms of treatment, including things like Ayurvedic forms, and then died of complications of medications. So we see this often. Unfortunately, it's not just arthritis; it's a serious condition, and we are in a serious business, and we need to take care of this. So back to my talk. What is a disease-modifying drug in osteoarthritis? To be classified as a disease-modifying drug, the FDA and the European Medical Associations require a substance to show structural outcome improvement. That is, it's chondroprotective, it decreases radiological progression, and it must show clinical benefit. So there are two huge components here. That's sort of similar to what happens in rheumatoid arthritis. We show decrease in X-ray erosions or a radiological progression, and we also show decrease in tender and swollen joint counts. So why both? We know why both. There are several substances which should make sense. For instance, fluoride. It does increase bone density, but it increases fracture, so it could not be used as a treatment for osteoporosis. What about tumor necrosis factors? We know that tumor necrosis factor is responsible for heart failure, but when we try to improve or treat heart failure with anti-TNFs, it actually increased heart failure. So it's very important to show the structural benefit as well as the clinical benefit. So the disease-modifying drug in osteoarthritis must show decrease in joint space narrowing. And when we talk about clinical benefit, we need to know what is a meaningful clinical benefit. Does it mean that we decrease pain? Can we define it as improving quality of life, or can we mean it as a delay to sending the patients to our friends in the orthopedic department? So I think it's all of these, but for the purposes of clinical trials, they define it as a decrease in joint space narrowing, and there are various definitions of it, ranging from 0.5 millimeter progression in X-rays of the knees over 1 year to other such definitions which are used in clinical trials, which we won't go into. It's beyond the scope of this talk. But also decrease pain, and the way we measure pain in osteoarthritis is usually through the WOMAC, or Western Ontario McMaster's scale for pain, which is a commonly used pain scale for osteoarthritis trials. So why are we so hung up on joint space narrowing? You know, cartilage narrows, but we also have to remember that not all the pain in osteoarthritis is coming from joint space narrowing or cartilage loss, because cartilage is avascular and aneural. But joint space narrowing also measures other things. It measures meniscal loss, and it measures other factors within the joint. So it is okay to measure the narrowing of cartilage, even though a person can progressively lose cartilage, and as we've seen, or as I said before, they can remain asymptomatic. So there have been many challenges. We do not have a disease-modifying drug for osteoarthritis. And why? Because it's so variable. This disease is so heterogeneous, unlike rheumatoid arthritis or ankylosing spondylitis. There's a variable progression of disease. I may have a grandmother who has severe loss of space and doesn't need a joint replacement. She's walking around, little bow-legged, but she's walking around, but very variable. The current radiographic techniques are not sensitive and not specific. MRI is the gold standard, but expensive, so we still have to rely on X-ray. The animal models are variable. There's a lack of consensus of that. The biomarkers, there's a variety of biomarkers which are really expensive for cartilage loss, many biochemical markers, and these are not something we can use in clinical practice to assess them because they're expensive and also variable. And the costs have been extremely prohibitive for studies. Phase 2 and Phase 3 clinical trials have been extremely expensive. And also because we've shown that sometimes, as we'll see soon, sometimes we can improve function or symptoms and we don't improve structure, or sometimes we improve structure and we don't improve symptoms. So this has been a huge problem, unlike rheumatoid. We get rid of the swelling in the joint and you prevent radiological progression almost always, but not here. And because it's such a common and ubiquitous disease, osteoarthritis, people do not tolerate side effects for patients with osteoarthritis, because everyone has a little bit of osteoarthritis. Another picture, this is the next World Arthritis Day. Again, we did another painting. No one died in this picture, thank God. So very busy slide, but have some patience. We're going to lead you through this slide. All right, here is synovium. And you see that in the synovium, you can have cytokine release, just like with rheumatoid arthritis, interleukin-1, TNF, TGF-beta play an important role in both, not TGF-beta, play an important role in synovial inflammation and hypertrophy. And there is here nitric oxide, very important component. These are things which I will refer to later. MMP, matrix metalloproteinases, very important in the pathogenesis of arthritis. Then we have the bone. This is bone here. There is subchondral bony restructuring or changes in the subchondral bone. We see subchondral sclerosis, and the subchondral bone has many changes in osteoarthritis. And we also have osteophyte formation. This is an osteophyte there. And again, this TGF-beta could influence these things. And the cartilage itself can be breaking down. And when the cartilage breaks down, it releases many cartilage breakdown products and also cytokines and inflammation. So where do we work? It's really hard to know where we work because not everything is linked together here, and it's a very confusing picture. Let's just start with various products and look at what happened here. The most common thing, diacerin and glucosamine, what words classify as nutraceuticals rather than pharmaceuticals. They don't require FDA approval for use in the United States, and they're commonly used. Almost all of our patients are taking them. They apparently thought to work through inhibition of the matrix metalloproteinases and interleukin-1. Diacerin, the first 3-year study, showed that the X-ray progression decreased in hip osteoarthritis by 0.5 millimeters. There was 62% of placebo patients had progression of disease versus 54% of patients on diacerin. So some mild benefit, but a recent 1-year study showed no structural or symptomatic benefits. So it doesn't work. Glucosamine and chondroitin, the GATE 2006 study published in the New England Journal of Medicine by Clegg and colleagues.